You are listening to Medicine and the Machine with Medscape Editor-in-Chief Eric Topol and Master Storyteller and Clinician Abraham Verghese as they talk with experts around the globe about the hottest topics in healthcare. This podcast is intended for U.S. healthcare professionals only.
Hello, this is Eric Topol, and I'm really pleased in our Medicine and the Machine podcast at Medscape to welcome Dr. Linsey Marr, who is the Charles Lunsford Professor of Civil and Environmental Engineering at Virginia Tech. She's been a leader in the pandemic and well before this on interactions of viruses, nanomaterials in the atmosphere. So welcome, Linsey.
Thank you so much for having me. I'm really excited to be here.
You have been a phenom, and I've learned so much from you in these years of the pandemic. I'm so impressed. So I thought we could get started. Obviously, the COVID airborne story. Can you help? And by the way, you are the lead person I follow to learn about this field. Can you kind of review what went off the track and how, if we are going to get back on it?
Oh, thanks for your kind words. Yeah, I think we were off track to begin with because the default assumption in medicine was that respiratory pathogens, colds, flus, other things were transmitted by large droplets that people cough out that either sprayed and landed in someone else's eyes, nose, or mouth, or maybe landed on a surface or hands, became contaminated. People would touch that and then transfer the pathogen, the virus or bacterium, into their eyes, nose, or mouth. And so that was kind of the default assumption for several decades, I think, leading up to this. There were some exceptions to the rule, and those were things like measles and tuberculosis. But otherwise, people just assume that these types of diseases were transmitted by large droplets that, again, kind of sprayed into someone's face. And so when COVID-19, SARS-CoV-2 came about, that was the assumption. And so I remember there was an article in the New York Times published in January of 2020, was about 6 key questions about how bad will this get? And one of the key questions was, how far does the virus travel in air? And they said, well, coronavirus, the novel coronavirus, doesn't travel more than 6 feet, so we don't have to worry about it. In contrast, we have things like measles and chickenpox that can travel hundreds of feet. And so, I think things were kind of off the rails, but it didn't matter that much. And, I've been studying flu transmission for 12, 13 years now, and I kind of knew things were inaccurate, but nobody listened to what some other aerosol scientists and other experts and I were saying, and it didn't matter that much. We just had this kind of background level of disease, but now all of a sudden it really mattered.
Yeah, and it was, of course, not just the World Health Organization, but the CDC that was reluctant to accept data that this was not just, or not even a droplet story, but rather that this was truly aerosolized. Why is this just a reflection of unwillingness to be receptive to new ideas? Or, I mean, you knew about this for quite some time, and you and your colleagues, other leading scientists in this space, which is not one that we've covered adequately to the medical community, I have to say. You were clamoring about that we need to change our views or update our views, but there was great resistance to that, right?
Yeah, I think it was really just it was in textbooks that this is how diseases transmit. So I think that's what medical students learned from a textbook and then took to be true. And so I think it's hard to change people's minds when they've learned something in a textbook. There was also additional resistance to the idea of airborne diseases because in healthcare and hospitals, that term carries a lot of weight in terms of precautions that are required by healthcare workers and the facility. If a disease is, quote, airborne, that means that everyone has to wear N95s, the patient's supposed to be in a negative pressure room called an airborne infection isolation room. These things are resource intensive. And so I think there's some reluctance, of course, to do that, unless you really have to. Furthermore, even if they did acknowledge the disease was airborne, there simply are not enough resources, not enough of these types of facilities in the world to accommodate the number of patients who would have to be in those types of rooms. But that said, it doesn't have to be all or nothing, because if you know that the disease is airborne, okay, well then N95s, using a lot more N95s on people than we have been would really help cut down on infection transmission and infections. It doesn't have to be a negative pressure room for everybody. There's other things you can do to reduce the risk of transmission. So I think that was some additional reluctance. And then, I think it's what people learned in textbooks, and then kind of reluctance among healthcare facilities to say, okay, this is airborne. Now there's a whole lot of other things we need to do to protect our healthcare workers.
Yeah, that's a really great point. I hadn't realized the implications for medical facilities and how that would feed into the resistance. In general, as you know, whenever there's some kind of wholesale change about a concept in medicine, there's a reluctance. It's kind of an embedded, a sacred cow, if you will, and it's hard to debunk this stuff. At any rate, so that brings us to mass, because as you've already touched on, N95s, perhaps KN95s. And also I want to talk about filtration and ventilation and humidity and these other features. But there's, just as there was or lack of receptivity about airborne aspects, there's also been, of course, tremendous backlash about masks. And to say, well, where's the proof? And I kind of look at it like, do we need proofs for parachutes that they work? But obviously there have been a lot of studies, and every study that comes out, they're taken apart by these anti-mask people. Can you help us understand, do you really need, for a respiratory virus that's airborne, do you have to prove? And of course, there's been all these simulation studies. What constitutes proof, or do you even need proof?
Yeah, I would say the proof is, do you know that the mask reduces, if you're looking at how much the mask has source control, or putting it on people who are infected to reduce the risk of their transmitting to other people. The proof you need is, does the mask reduce the amount of virus that they expel into the air? And then on the other side, the proof that you would need is, for protecting people from getting infected, from breathing in the virus from the air around them, the proof would be, does it reduce the amount of virus that they breathe in enough to reduce their risk of infection? And so that, to me, is the type of proof you need. I know there's a call for randomized controlled trials. Those are really hard to conduct in the proper way when you're trying to look at masking. It's hard for people to wear them all the time, of course, but that's not the question you're asking. You're asking, does it reduce your risk? Not does it completely prevent transmission, but does it reduce your risk of transmission? And there's plenty of other types of engineering approaches. You mentioned parachutes, there's seat belts, there's lots of other analogies we can look at where there are physical mechanisms that explain how this protective equipment works. And do we, or even should we, have to put ourselves through a randomized controlled trial to show that? No, in some cases it's unethical, in other cases it's simply not needed. And so, that's some of the background on kind of some of the resistance to masks. Of course, I think it really originated with the shortage of supplies for healthcare workers, which led, even the head of the CDC at the time to say, oh, don't buy masks for the general public. I think it would have been better for them to be honest and just say, look, there's a shortage for healthcare workers. Please, use what you can, that you have cloth masks, other things, but not that don't buy them or that they don't work. There's another aspect of this about N95s and kind of the way that our country regulates respiratory protection, and the way that OSHA, the Occupational Safe and Health Administration, regulates it, which is that if you're going to, if you require respiratory protection for workers, then it has to be a fit-tested N95 to show, fit-tested to show that it's not leaking and that it is doing its job. And I think the attitude in that sphere is that it's N95, fit-tested N95 or bust. Like, if it's not a fit-tested N95, then it is worthless. So that was the attitude. Even though we know that, okay, maybe even if it's not perfectly fit tested, it still is going to provide you some protection, and probably a lot more than a flimsy cloth mask.
Sure, sure. Well, let's say you're wearing a KN95 or an N95, which a lot of people who are conscious about this do today still. I think, or with the triple demic, we're going to talk about these other pathogens in a moment, whether it might help with that as well, things like flu and RSV. But if you're wearing that and you're among people who aren't wearing masks, like on a plane or in an airport or other public transport, as we face in the US, I wonder if you could just give us your estimates about the protection. It's obviously not 100%. Especially because, as you say, most of these people in the public, they don't have fitted masks. They do their best, many, to make sure that they have a tight fit, but it's not, perfect by any means. But can you give a sense about two-way masking, one-way masking, and how much we can expect to get from that in terms of reducing the risk, not just of COVID, but perhaps other respiratory viruses?
Yeah, I'd be happy to. So let's say that you have 100 virus particles that are in the air that you might breathe in over the course of your plane flight. They're floating around in the air. Now, if you're wearing a mask that's, let's say, 90% efficient at trapping those virus particles, then instead of breathing in those 100, you're going to breathe in 10 of them, right? Because 90% of them were trapped by the mask. Now, can you still get sick with 10? Well, it depends on the virus. It depends on your immune system, some other factors. But you've reduced your exposure from 100 down to 10. That it has to be helpful, right, in reducing your risk. Now, the other thing is that if only you are wearing masks. Now, if everyone is wearing masks, then those 100 viruses in the air, they wouldn't be there. They wouldn't all be there. Let's say that, okay, the person who was spewing them into the air is now wearing a mask, and maybe they would have released 100 before, but now they're masked, and now they only release 10. So now there's 10 floating around in the air. You're wearing your mask, which is 90% efficient. And so now, instead of breathing in 10, now you're breathing in just 1. And so this is how two-way masking helps. It reduces the amount that gets into the air, and it helps reduce the amount that you breathe in from the air around you. And that's true. That will work really for any virus that's in the air, not just SARS-CoV-2, but also flu virus, and really probably most respiratory viruses. People talk about the size of the virus particle itself, but what really matters is the size of the respiratory droplet or respiratory aerosol that carries the virus, because we don't have naked viruses floating around out there in the air. They come out in tiny droplets of respiratory fluid. Some of those evaporate, but there's all this other kind of respiratory goo that's there with the virus.
Yeah, and so what I find interesting is when I suggested that you get a threefer by wearing a KN95 or N95 for the triple demic, and that RSV stands for respiratory syncytial virus, and people write back on Twitter or social media, where's the proof? Where's the proof? Well, I mean, you would think it would help. Do you need proof? I guess that's one question. But the other thing is, you come at it from a different discipline, from engineering. And, engineering may not be rife with randomized trials. You depend on, different types of standards for proof, which you just reviewed. So could you comment about why is there such questioning if indeed these are aerosolized viruses? Masks can't hurt, right? I mean, they have to help to some degree. And by the way, I love that explanation of the one and two-way masking and how that helps. But I just don't get this continued questioning, resistance. I mean, yeah, maybe people feel they can't breathe well when they have a mask on tightly. I understand that, I guess, or feel claustrophobic, but comments about this issue, because it's just never ending.
Yeah, I think with RSV, again, the default assumption is that these diseases are transmitted by large droplets. They're not airborne, so you don't need a high quality mask. And some of the thinking about RSV may come from one particular study that's well known, where they had nurses cuddling with infants who were infected in a hospital. And then they had other people kind of at a distance, and they found that the cuddlers were most likely to become infected themselves when cuddling with the infants who had RSV. and so it was presumed that, oh, this is large droplets transmitting or close contact. But you have to remember that when you are close to someone, you're also exposed to much higher amounts of any viruses they may be releasing in air. Kind of if that person's smoking, and we know babies don't smoke, but if a person's smoking and you're close to them, you're going to be exposed, breathe in a lot more cigarette smoke than if you're farther away. The conclusions of that study, to me, that study is inconclusive in terms of transmission route, because when someone's close up, it could be a number of different ways that the virus is transmitting. But again, so I think, people have presumed that RSV is not airborne, but in the Cuddler study, it very well could have been. There was another study where they did sample the air. They found infectious RSV, not just the RNA, the genomic material, but actual infectious virus in the air. I think that was in some kind of healthcare facility in very small particles that would stay aloft, floating around in the air for many minutes to hours. I've been collaborating with a team of experts, of virologists, epidemiologists, and we're looking in daycare centers, and we find RSV in the air more often than we find it on surfaces. So I think we need a paradigm shift, really, and I think the default, it would probably be more correct that the default assumption is that these respiratory pathogens are transmitted through the air. They are respiratory. So it doesn't seem like it should be that big a leap. But it's hard to change things. I almost see it as, people for a long time thought that the sun revolved around the earth. Then it took a real effort, and it was painful. And people thought Galileo was crazy for suggesting that the earth revolved around the sun.
Yeah, that's well put. It really is. Now, there are modifiers in our space, particularly, let's say, indoors, where humidity, you posted earlier about pH and other factors that we can do with ventilation and filtration. Can you kind of give us the skinny on what we can do? What are the optimum or the worst scenarios for infections in indoor space?
Yeah, certainly. One way of thinking about it, because we can't see these things in air, so it's hard for people to think about it. But one way of thinking about it is, okay, you have a glass of water and it's dirty. Are you going to drink that? And so, no, you're going to treat that water, do something to remove the dirt and other pathogens that might be in there before you drink it. You want it to be nice and clear. And so that's how we should be thinking about our air. If there's lots of infected people around, they can be releasing virus into the air can be contaminated. So there's several different ways to attack that, to clean the air. One is through ventilation, where instead of being in a sealed room where there's no ventilation, imagine people are smoking and the smoke just builds up over time, gets very thick. Well, if you open the windows or use your mechanical HVAC system, you can kind of blow some of that out of there and bring in some of the cleaner outdoor air to replace that. And so you're diluting it and really just kind of flushing it out of there. So that's one way. Another way is to run better filters in the room. So there's portable HEPA air cleaners that you can buy, for a bedroom, maybe $200 or $300 for that size room, that passes the air through a very high quality filter that removes almost all particles from the air, not just viruses, but other things. So people with asthma and other sensitivities to particle air pollution can benefit from this. So that would be like taking your glass of water and pouring it through some really great filter. And so all you get your Brita filter, and what you get through on the other side is your nice clean water. And then there's other techniques that are used in hospitals, for example, and that's UV, germicidal UV radiation, which doesn't physically remove the viruses from the air, but it will actually kill them off. And so that's not something that people are going to have in their homes. But if you are in hospitals have that, I think it'd be a good idea for crowded bars and restaurants to have that type of treatment too.
Well, let's say if we could have a magic wand and fix our schools and buildings, which are desperately not well equipped to handle this issue of filtration. What would we do to increase our protection, not just against in the current pandemic, but for future respiratory viruses that inevitably we're going to see, future, unfortunately, more pandemics in the years ahead?
Yeah, that's a great question. I think one of the first things we should be doing is ensuring that our existing mechanical HVAC systems are working the way they should be. So I know it sounds very basic and very boring, but we have these HVAC systems that were designed and installed 20, 30 years ago, and maybe have barely been maintained. Maybe, they should be checked every few years, and they're probably in many cases not being checked and making sure that they are operating as designed. So you do that first. Then there's ways to try to adjust the settings on that to bring in more outdoor air or to run it through more filters. And so instead of our classrooms, for example, we talk about ventilation rates in terms of air changes per hour. So 1 air change per hour means you take all the air in that classroom and you kind of remove it and replace it with cleaner outdoor air once per hour. Now, if you do that 3 times per hour, that means once every 20 minutes or so, you are changing that air out. And so people are, things that might build up in the air are being removed. And so I've been on several committees, and we've recommended aiming for 6 air changes per hour, which is what is the minimum in hospitals in patient areas. So that means that 6 times per hour, or once every 10 minutes, you are flushing that air out. And you can see how that would really reduce the amount of virus and other pollutants that can build up in the air over time. That's, I think, one basic recommendation. And it's going to cost money, and there's energy considerations too, because that's going to affect heating and cooling costs. But there's a lot of benefits to be gained here, not just for the current pandemic, but also for the other respiratory pathogens that we talked about. So flus, colds, RSV, and then other types of air pollution that people are exposed to. That's really one of the leading causes of death around the world. I mean, exposure to particles in the air is responsible. It's estimated to cause 7 to 8% of premature deaths per year. And so, a lot of that happens indoors. Some happens outdoors too, but, cleaner indoor air can help with that. And so this comes down to not just cardiovascular disease, but for school kids, we're talking about absences and asthma attacks, and academic performance even is linked to air quality. So we're getting a little farther afield here. We're not just talking about viruses and respiratory infections, but if you are trying to attack those, there's a lot of co-benefits to having cleaner indoor air.
Yeah, I'm really glad you brought up these bonus factors, because it's impressive, and I don't think we've underestimated the effects of pollution, air pollution, on health, and there's been some recent important studies on that, just as you mentioned. Now, what about humidifiers? What if we enhance the humidity in indoor space? Does that help much?
The evidence there suggests it could. It's not a sure thing, but I can tell you, and my group really specializes in trying to understand how well viruses survive in indoor air under different humidity conditions. And it's a fascinating topic for me, of course, because now we're talking about looking at an individual aerosol particle and kind of what's going on as the water evaporates. You mentioned the pH can change. Other things with the respiratory goo can change, and so that can affect how well the virus survives. I will say that not conflicting results, but a lot of different types of results out there that we haven't put completely together. But I will say that there's overwhelming evidence that these types of viruses survive very well at very low humidity. And so we need to think about the indoor humidity. During the winter time, we heat our air, maybe not so much in San Diego, but in the rest of the country. We heat our air, and the indoor humidity ends up being like 10, 20% in some cases. And that is the perfect type of condition for these viruses to survive a long time. Mm-hmm. And so if you can increase that humidity up to maybe 40%, 40 or 50%, then a lot of studies find that the viruses don't survive as well under those conditions. And maybe that helps explain some of the seasonality of these respiratory viruses. Why do we see them more in the wintertime? I'm sure there's many factors that explain that, but this could be one of them. And so, these are laboratory studies showing this. There's other epidemiological studies, so looking at kind of relationships between the number of people who are getting sick and what the weather is like. And they find also this relationship where, okay, if you take your indoor wintertime humidity and you increase it a little bit, maybe you'll get less transmission. And then finally, there's been one small pilot study in Minnesota where they humidified some classrooms, and they did find that there were fewer cases of influenza-like illnesses in those classrooms and less virus in the air and surface samples in that classroom. And that was only 2 classrooms, but I think it offers a hint of, or suggests a direction that we should go for further study. Because if you keep the humidity higher, maybe that will help reduce transmission in your household or in these other environments. And it's, as I mentioned, it's probably other factors too, not just the ability of the virus to survive, but our immune response also seems to be better when the air is a little more humid rather than just bone dry.
Yeah, another critical point there. You touched on this earlier, but I think it's such an important translational point or practical point is if you can smell the cigarette smoke or the perfume or whatever, that's the aerosol content. And the question, I guess, is also regards to outdoor transmission. Because we have basically said, oh, well, don't worry, you can't transmit these respiratory viruses outdoors. Can you get us straight on that question?
I think transmission can happen outdoors. I've seen some pretty good evidence of it. I would say that it is mainly occurring when people are in close conversation and more than just hello, but standing there talking with someone for a few minutes. And in that case, that's not surprising because as I mentioned, using the cigarette smoke analogy, even if you're outdoors, if you're close to a smoker, right in front of them, you're going to be breathing that smoke. But you also know that if you're farther away, it rapidly dilutes in the atmosphere. So I like to talk about, well, if you're indoors, think about putting a drop of dye in a glass of water. Okay, it can't go very far, versus putting a drop of dye into the ocean. So that's like outdoors. So if you happen to be right near that drop in the ocean, you are going to be exposed. But if you're a little farther away, there's almost nothing because it just becomes very diluted. So I do think transmission, I'm sure it is happening outdoors on occasion, but the risk of it is much, much lower outdoors than indoors because of this huge dilution that happens in outdoor air. And so, if that's something people are concerned about, I would say avoid the close, extended face-to-face conversations. I suppose it could also happen if maybe you're at a restaurant outdoors and there's a table upwind of you and someone's infected there and you're sitting there for an hour. Somebody's a super emitter there, they're releasing a lot. And maybe if you're right downwind of them, you could end up being exposed and catching the disease. But again, I'm sure it's much, much rarer than indoors.
Yeah, I know that point. Our son got COVID from an outdoor restaurant where he had, a dinner with a woman for over an hour where they were, face to face talking. And then she was pre-symptomatic. So then a couple of days later, so yeah, it can happen. But as you say, that was extended contact. It doesn't have to be an hour either, of course. So we've reviewed some really important material here that's not just practical, but I think emphasizing the science, the work that you do, which is really quite extraordinary, and it never has become more important. This, to me, exemplifies why, when you have such a crisis that we've faced for now a few years, why you need transdisciplinary expertise, and that we don't do that enough. And you are, I think, one of the best explainers I've had the chance to meet over the course of the pandemic, not just today, but of course on your posts. And you're not just on Twitter, which is troubled times in Twitter, but also on Mastodon. I don't know if you're also on posts, but I really want to encourage people, if they want to keep up with the latest science in this domain, that Dr. Marr is the go-to person, in my view. There are others, of course, but I don't know anyone who's more lucid in explaining and also keeping up with the ever changing new papers that are getting published in this space. So any further comments that you want to make to the medical community before we wrap up, Linsey? Because obviously we've only scratched the surface. We've touched on some, key practical issues and tried to put this in perspective, but I'm sure we've missed some things that you think are worth emphasis.
Well, first I want to say, Eric, that you are the great explainer of all things medical. I've learned a ton from following you on Twitter and now Mastodon or wherever we may end up. You touched on how the importance of transdisciplinary research in this area. And, I want to emphasize that all the research that I've done with my collaborators over the past decade plus has been very transdisciplinary and would not have happened without the cooperation and collaboration of virologists, medical doctors, and epidemiologists. And so let's do more of that. And I think we need to respect each other's fields and expertise, and see how we can contribute to help each other understand our own fields better.
Absolutely, that deserves the utmost highlighting, because I think if you go back and you say where the missteps were in the first months, even years of COVID-19, had we listened more to people of your expertise, we might have gotten ahead of it earlier in terms of this critical aspect. Well, thank you so much for joining us today. We'll continue to follow you, and all I can say is you're a gem, and thanks for giving the time to us to be explaining critical aspects that just are not still emphasized enough. And hopefully someday they'll sink in and we won't keep demanding randomized trials for masks for respiratory viruses. Thanks, Dr. Marr.
Thanks so much for having me. It's been a real pleasure.